Mr. Mark, friends, thank you very much. I must say at the outset that I'm standing in this session for my minister who addressed the session in the morning on the same subject. And I would just like to follow the outline he used. People know of India as a huge technology center. And one indication of this, I think, is that in a country of 1.2 billion people, there are currently 925 million mobile users. And so this is clearly, so if we exclude the very old and the very young, it's pretty much everybody, cutting across income levels. So clearly there are a large number of people who do not have access to a great many things, but certainly have access to a mobile phone. And this has certainly changed the way in which people do business in India. In 2011 alone, an additional 142 million mobile subscriptions were added, and we are believed to account for more than 10% of the world's online population. So this is growing very fast. These figures was 700 million only a couple of years ago, and so it is something that's going very fast. It is also cheap. 15 cents per month was a figure that I have seen, and clearly the indications are that this will become cheaper. Now, I'd like to talk about three specific examples where, through government intervention, mobile technology is being used. And one is a very recent initiative to track mothers and children. That in any year, at any point of time, there are 27 million pregnant women in India. And one of government's major tasks has been to put in place a universal immunization program up to the age of 5. So this means pretty much 100 million plus children at any point of time who need to be going through a course of vaccination. We've begun to put in place a system by which every pregnant mother is tracked by name, address, and mobile phone. And this information is shared not just with a central data bank in the ministry, but with state-level data banks in our federal system, and also with the district and block-level field workers, the accredited social health activist, the nurse midwife. This system also enables, essentially, to track the fact whether the pregnant woman has had her antenatal checkup, whether after the baby has been born she's had her postnatal checkup, whether that baby has been going for vaccine inoculation on schedule. One interesting aspect of this is that I mentioned the accredited social health activist. This somewhat odd name was, I think, chosen more for the acronym ASHA, which translates in most Indian languages as hope. But there are now 860,000 accredited social health activists, women who with school-leaving qualifications, but who have proved extremely capable in handling this technology and in being able to exchange information very, very effectively. The second example I'd like to give is of the central government health services. Government of India is obliged to provide healthcare facilities to central government employees, both serving and retired. And there are slightly over 3 million such persons at this point of time. And a very elaborate scheme has been put in place by which all CGHS beneficiaries are tracked, their address, their location, and their particular healthcare requirements. The third example I'd like to give, again very recent, is screening for diabetes and cardiovascular disease. Now, this has been taken up as a pilot activity in 100 districts of the 643 districts in India. It involves essentially screening using a glucometer for all persons over 30 and pregnant women of all ages. This depends crucially on both the collection and document and storage and transmission of information. It is the results have been quite surprising. I don't believe we have the 25% we heard of in Kuwait, but what has been important is that the districts chosen are comparatively remote, not very well provided with health services, and so essentially a lot of people being screened who would not, under any circumstances, have sought health assistance of any sort. It certainly would never have occurred to them that they were possibly diabetic. And this information is coming out. The challenge, of course, now is to be able to provide those services, the services that they would need in terms of treatment. I would like to add to these three examples which my minister made in the morning presentation with one which is slightly different, because the three I've mentioned basically relate to information collection and storage and how you can use that information. But very recently I came across an extremely interesting case of technology, mobile technology application, which is Bangalore based. Bangalore, as many of you would know, is the hub of India's IT industry. And a very fine eye care institution, the Narayan Nethralaya, has begun working with retinopathy of prematurity. Now, in a country where a very large number of pregnant women are anemic and or underweight, the possibilities of low birth weight premature babies is very high. And I'm not a doctor, but I'm told that there is a distinct possibility of retinopathy in underweight babies. Now, this is an absolutely marvelous technology application, because these accredited social health activists have been trained to immediately, as soon as the baby is born, to take some sort of photograph of the eyes, I suppose. And this is transmitted to Bangalore, where the people at the Nethralaya look at it and identify the cases that need more attention. More photographs are taken. And when I looked at the figures in 6 districts, in a period of 6 months, they'd made 700 surgical interventions of children who would otherwise have gone blind, perhaps. So this is, I think this example struck me as very important, because this is not just information sharing, but there's something actually happening. That as a result of using this technology, there is a child who would have gone blind who is now able to see. And I think that is quite remarkable. Well, thank you. That's as much as I would like to say, and we're glad to take questions. Thank you.